I'm honored to be here and represent the almost 63 million people living with or at risk from cardiovascular disease due to high Lp(a). As a show of hands, how many of you have a family history of cardiovascular disease? That was me. My disclosures. What we know. Cardiovascular disease is the leading cause of death for people in the United States. If we do nothing about cardiovascular disease, it's going to cost $47 trillion in the next 25 years. These statistics would have piqued my interest a number of years ago. My father died young of a heart attack. He had his first event at 30. He had bypass surgery at 40. It was actually a femoral bypass. And he died of a massive heart attack when he was 50 years of age. This foundation and presentation is dedicated to my father. It was never going to happen to me, though. I was doing everything right. I was, even in the medical device industry, I was positively arrogant. I was 16% body fat when I was training all the time. I had a non-fat diet. I taught aerobics. I thought I was doing everything right. This was my Framingham risk score. It gave me a 1% chance of having an event. This was my Reynolds risk score. It gave me a 1% chance. And one of these even includes family history. I went for an annual checkup every year because of my family history of cardiovascular disease. And if you add lipoprotein (a) based on the Bruneck study to the Framingham and Reynolds risk score, you reclassify 20% of patients into a higher risk category. These are some of the faces of high lipoprotein (a). What we know. Lp(a) test is not included as part of the regular lipid panel. 50% of hospital admissions for coronary artery disease have normal LDL-C. 63 million people in the United States are unaware of their risk. That's 1 in 5 Americans. Lp(a) currently is the strongest genetic risk factor for coronary artery disease and aortic stenosis. Increasing evidence reveals that high Lp(a) is a genetic independent and causal risk factor for coronary artery disease, atherosclerosis, thrombosis, stroke, and aortic stenosis. What we know, the clinical evidence. We have epidemiological, Mendelian, randomized studies, genetic association studies, but we don't have a randomized control clinical trial on a therapy that specifically lowers Lp(a). There are some potential things on the horizon. There is hope for us. The vision of the foundation, the reason the foundation started was because my father lived 10 years after his bypass. And I, at 39 years of age, went out for a run, and I got a block down the road. And I couldn't go any further. I'd run a marathon the year before, and I thought, I got thyroid issues, early menopause, flu. So I went to my regular family physician, and they knew my family history of cardiovascular disease. And I had a regular treadmill test, which I passed with flying colors, and I went and taught spinning, cycling that night. I got off the bike 2 or 3 times. I thought, this flu's not going away. I then went to Washington, D.C., and I was with all the top interventional cardiologists in the world, running on the treadmill, feeling terrible. My feet had swollen up, and I started to take aspirin to try and reduce the swelling in my feet. They think the aspirin may have actually saved my life on the plane home. When I got back, I self-referred myself to an interventional cardiologist that I worked with, and he did a thallium stress test, and he called me in my office, and he said, Sandra, I need you in hospital first thing tomorrow morning. I'm like, what? He said, yep, there are several abnormalities on your test. So I went in, heavy-duty blood thinners overnight, and they shot the dye into my artery. I looked up, and he said to me, Sandra, I think your dad is sat on your shoulder right now. He said, and we're not quite sure how you're still here. And I said, can you fix it? So they stented it. And it was a 95% occluded proximal LAD. I was imminent to have a widowmaker heart attack at 39. So the vision of the foundation is to live in a world where Lp(a) is routinely diagnosed, treated, and family screened. Our mission is to reveal this inherited lipid risk for premature cardiovascular disease, to educate and empower patients and save lives. Our goal is to save lives by increasing awareness, advocating for routine testing, and a specific treatment for high Lp(a). After I came out of the cath lab, I was with my doctor and I cried. I said to him, what did I do wrong? Because, you blame yourself. You're fat and lazy. You did this to yourself. Well, I had worked out my whole life and watched my diet because of my dad. And he said, Sandra, we couldn't believe it. He said, I ran this additional blood test and you have high Lp(a). He said, you didn't do anything wrong. And that was the beginning of my journey to find out about high Lp(a). He said, you probably inherited this from your father. Well, my brother, a couple of years ago, had triple bypass at 45. So 2 out of the 3 of us inherited from my father. Our objectives with the foundation are advocacy. We would like to have a registry and more clinical trials targeting Lp(a). Lp(a) as a risk target in the guidelines, not just a risk factor. A standardized assay for Lp(a) and testing including in the standard lipid panel. Early detection, which is what you guys are all about, prevention. Accurate diagnosis and proper treatment. We offer community education. Patients need to know their risk. They need to have an accurate prediction of their risk so that they can have a preemptive strike before your first symptom, which may be death. From a patient support point of view, we want to empower patients and their families to partner with the healthcare provider to take control of their inherited cardiovascular risk. We would also like a reimbursable ICD-10 code for high Lp(a) and to offer equal access to treatment and care. What you should do. We'd like you to support our objectives, learn about the latest information on Lp(a), and we have a booth in the exhibit area, and tell your patients about us. For 10 years, I thought I was the only one that had this disease. And it's a very isolating thing. And as you know, depression exacerbates your disease state. So developing a community where we can provide the best evidence-based data to date to patients so that they can talk to their patients and make calculated decisions about their healthcare is extremely empowering, and they can actually participate and actively get involved in their care. So the conclusion. Lp(a), currently the strongest genetic risk factor for coronary artery disease and aortic stenosis. 20% of people in the US are unaware of their risk. That's 1 in 5 Americans. Patients need to have an accurate prediction of risk for premature cardiovascular disease to prevent the first symptom from being death. In a recent paper that was published by Mortensen and Nordisgaard, they took 10,000 patients and took the new guidelines and ran them through it. And 8% of those patients were missed by the new guidelines. Do you know what those 8% patients had? And it was their only risk marker. It was high Lp(a). And the editorial that Valentine Fuster had along with that was, he suggested, let's begin to pay attention to Lp(a) because it may explain cardiovascular events in patients who otherwise do not have a significant risk factor profile. And there are 1.5 million people in the US that have a cardiovascular event every year. 8% of those is 120,000 people. I'd like to thank you for your time and look forward to seeing you for you to get more information about Lp(a) at our booth in the exhibit area.